we have the next speaker, Dr. Wulan. Dr. Wulan is going to be speaking on interventions for chronic pulmonary arterial hypertension, CETPH. In fact, it makes me very proud that all the three speakers have actually been to Delhi and worked with me. And it gives me a very proud feeling, and all of them are leaders in their own country. So Dr. Wulan, please carry on with your talk. And I believe Dr. Ramesh Singh, Arjun Singh is on the panel. I will want him to actually lead the proceedings.
Thank you, Dr. Khanna, and thank you all the attendants and panelists this evening. So some interventions in chronic pulmonary hypertension, we just specifically will describe a little bit about CTAP. Here we have a male with 24 years old of age, and in 2014, when he was working, when he worked in Taiwan, he had a right-sided leg swelling, and he was given oral medication, and it recovered for about 2 weeks, or even later about 4 weeks. And since then, he never complained anything. And in 2016, he returned back to Indonesia in one of the district hospital. He came with the complaint of hemoptysis and diagnosed with and treated as pulmonary tuberculosis, as this is rather common in our country, that people with hemoptysis, they would rather diagnose it with tuberculosis in district hospital. And eventually the patient developed right heart failure, and they provide him with medication for the congestions and continue with the treatment of pulmonary tuberculosis. In 2020, he was referred to our hospital with quite severe right heart failure with class functional of 3. And we from the echocardiography, and it showed typical signs of pulmonary hypertension, and we found a thrombus in the just septal leaflet of the tricuspid valve. Even in the TEE, we found thrombus in the RVOT, so we highly suspect him is having thrombus as well in the pulmonary artery, but he didn't show any signs of acute massive pulmonary embolism at that time. So we performed a duplex ultrasound in both of his leg, and we found the partial thrombus in the right femoral and popliteal vein, and it quite answered our question that this might be the cause of his symptoms since 2014 or 2016. In 2020, in that time, our team did a peripheral vein angiography, and we found an occluded left iliac vein and partially occluded right-sided femoral popliteal vein, and the patient underwent successful balloon angioplasty and had quite a good flow for the bilateral lower extremity of the vein. And then for the next 1 year, we provide him with an oral anticoagulation with in 2020, again, we did a CT scan, and we found quite a large thrombus in the ostial of the left pulmonary artery. And since it's quite large thrombus up to the mid and distal of the left pulmonary artery, we couldn't see any flow, so we provide him with oral anticoagulation, sildenafil, as he showed any sign of pulmonary hypertension, diuretics, and digoxin. We also tried to refer him to the surgery for the pulmonary and arterectomy, but the surgeon shows some reluctancy. And since then, he was 3 times hospitalized due to the recurrency of the right heart failure with a high functional class. So just briefly, that DVT or may come up to acute pulmonary emboly, or just not treated well as for this patient, and he came with a symptomatic signs of right heart failure, which we suspect him either as having chronic thromboembolic disease or chronic thromboembolic pulmonary hypertension. So as for the final diagnosis, actually, we have to perform right heart catheterization to exclude if the mean PAP is more than 20 and PVR more than 3 Wood unit with the persistence of thrombus after 3 months of anticoagulation. Then the patient will definitely having a CTAP. So the treatment decision-making process in this patient is quite difficult, actually. So once we establish the diagnosis of CTEP in this patient, actually based on the morphologic characteristic of the thrombus itself, this patient is indicated for surgical pulmonary atherectomy because the thrombus is quite large. It's in the osteoproximal of the left pulmonary artery, and it's kind of totally occluded or subtotally occluded of the lesion. But anyhow, when we see that the patient is operable, we have to determine the risk to benefit ratio for the surgical PEA, whether it's favorable or it's unfavorable. And if it's unfavorable, and we have to see whether the lesion is favorable for the BPA or not. Otherwise, we only what we can do is only giving the patient vasodilator therapy, as we give initially to this patient, because in our hospital, PA is the surgeon has not familiar with a PA, and the patient is having a very high risk due to the high functional class. So if it's inoperable, so we have to evaluate actually if the patient is having a high risk of operation, like in this patient. So we have to evaluate whether it's favorable to BPA or not. But in the initial days, we thought since the patient is having high risk and the surgeon is not having a good experience in PEA, and then the lesion based on CT scan is not favorable for PEA, we thought that okay, we initiate him with vasodilator therapy and quite a good control of anticoagulation orally. And then we evaluate the patient, but eventually in the 1 year of the follow-up, the patient has a readmission of 3 times. So 40% of CTEP patients are ineligible for PEA because the technical accessibility of the thrombus itself, like what we have in this patient, and the poor surgical candidacy. So yeah, some of the recommendation for performing BPAs, first, the selection of the target lesion is very important. So we have to define which kind of lesion of the thrombus in the pulmonary, distal pulmonary artery. And angiographically, if you have a ring-like stenosis or the web lesion or subtotal lesion, that we might be able to perform it. But if you have totally occluded lesion like what we have in this patient or tutors, and it might be high risk for the failure. And yeah, it should be done in multiple stage, and then we have to assess pulmonary gate flow scores afterwards. And then it's also we have to define the endpoints of target lesion every time we did the BPA, and define the endpoints and also the risk for having a complication of pulmonary edema. So back to our patient, actually, finally after he admitted for the third time, and he had a very severe condition and bad shape, and even he had a very high carbon PCO2 in the blood gas analysis, and we have to put him in non-invasive ventilation. So we try to think whether what we can do for this patient. And yeah, if you see the left pulmonary artery flow is very small, and it's just similar to what we had in the CT scan.
Dr. Wulan, kindly continue
Yes.
your slides, please.
I'll be fast. So we try to do the wiring using just the workhorse BMW wire, and we can go into the anterior branch of the left pulmonary artery. And then we try to do the sequential ballooning using a non-compliance balloon, but it was very difficult. So we changed the balloon into a non-compliance balloon. And then we first did it in the proximal, and then we do it sequentially to the distal. And yeah, apparently we can have just quite a better flow. And once we open the proximal, then we have a little bit better flow for the posterior branch of the left pulmonary artery, but still the size is very small. And then because we want to try to put the wire into the posterior branch of this branch, and it's a bit difficult to get the wire, so we do the double wiring and anchoring the other wire to the superior branch. And yeah, after that we just do the sequential ballooning, and then just finally, if you see if you see here, there's still a stenotic lesion, so we try to just do the ballooning at that part. So basically, what we can do is just opening that part of the posterior branch and also the anterior superior branch, but unfortunately, the other occluded part is very difficult to do the wiring because the thrombus is quite hard. So up to this stage, it was done like 3 weeks ago. This is what we can do so far, and we just wish that we can do more to the patient sequentially. And we have an MPAP of 83 millimeter mercury, and after that, just have a slight reduction about 6 or 7. So as a conclusion, the treatment options for CTAP are evolving, including endovascular therapy, and even now they are trying to find a good technique for the chronic total occlusion. And PPA might be an important therapeutic option for patients with CTAP who are not amenable for pulmonary and atherectomy. Thank you very much.
Dr. Wulan, that was great.